Can I have the voice, please? Our next talk is Updates in Clinical Approach to Dry Eye Disease by Dr. Ahmed Al-Maskari. Dr. Al-Maskari completed his ophthalmology training in the UK, and he obtained the fellowship of the Royal College of Ophthalmologists in 2013. Following that, he did 2 cornea fellowship, one at St. James University Hospital, and the other one is at Moorfield Eye Hospital in London. He's currently a consultant ophthalmologist and cornea and refractive surgeon, and he serves as the head of Oman Vision Center at Oman International Hospital in Muscat. He's also the director of training and continuing professional development at Sultan Qaboos University in Oman. Without further ado.
Thank you very much, Mahmoud, for the introduction. It gives me a great pleasure to be with you today, and I've been asked to talk about the clinical diagnostic approach to dry eye disease. This presentation is aimed at residents, optometrists, general ophthalmologist level, and probably a good introduction to the talk after this by Professor Shafiq. I have no financial disclosures to make. So we're going to touch on the definition of dry eye disease, quickly overview the pathophysiology of dry eye disease, and discuss the DUCE2 classification diagnostic methodology. Why talk about dry eye disease? Dry eye disease is probably the one main condition that causes misery. It has a significant impact on the quality of life. It even increases the risk of depression and suicidal thoughts in severe cases, and has a huge economic burden. It affects the ocular surface that is formed or consists of the tear film, cornea, conjunctiva, the eyelids, and the meibomian glands, and the main and accessory lacrimal glands. And we'll come to know that all these parts really need to work together in a homeostatic manner to ensure the vitality of the ocular surface. The tear film consists of 3 major components: mucins from the goblet cells mostly, and add to the viscosity and stability of the tear film. The aqueous component of the tear film from the main and accessory lacrimal glands, and it contains all the proteins, mucins, and electrolytes. And lipids from the meibomian glands, which stabilizes the tear film and prevents evaporation. Now, for those who don't know, the DUCE2 report is considered as a major reference in dry eye disease and a consensus from the work of 150 experts from 23 countries. And the universally accepted diagnosis nowadays for dry eye disease is that dry eye is a multifactorial disease of the ocular surface characterized by a loss of homeostasis of the tear film and accompanied by ocular symptoms in which tear film instability and hyperosmolarity, ocular surface inflammation and damage, and neurosensory abnormalities play etiological roles. And I've highlighted in this definition in red what I think is the most important aspects of this definition, and that's the fact that dry eye disease is a multifactorial disease, and the assessment and diagnosis focuses on identifying these factors, and the fact that dry eye disease is all about a loss of homeostasis, and our treatment revolves around restoring this homeostasis in dry eye disease. Now, DUCE2 report classifies dry eyes into 2 main categories: the aqueous deficient dry eye disease, which can be either autoimmune related, such as in Sjogren's syndrome, or for other reasons, such as lacrimal gland duct obstruction or reflex block. And then the other type of dry eye disease is the evaporative type, which is mainly related to meibomian gland dysfunction, lipid deficiency, and can be related to blinking disorders, topical drop and preservatives use, and contact lens wear. Now, if we look at the pathophysiology of dry eye, this is a very busy slide, but in essence, it has the aqueous deficiency dry eye factors on one side and the evaporative dry eye factors on the other, and they all come together to ultimately cause increase in tear hyperosmolarity. The increase in tear hyperosmolarity is what then leads to increase in production and expression of inflammatory markers on the ocular surface, which then leads to cell damage and ocular surface inflammation, and this in turn leads to further tear film instability and so on. So this inflammatory vicious cycle is the core of dry eye disease, and what we're trying to do in our diagnosis and management is to identify which parts of this cycle has the major component on the condition for the patient, and how we tackle the condition. Now, DUSE-2 report also has a proposed clinical approach to the assessment of these patients, which starts by asking triaging questions that lead to assessing risk factors, and then performing certain diagnostic tests to assess the homeostasis of the tear film, followed by tests to classify whether the condition is aqueous deficient or evaporative. And in real life, it's never a clear kind of cut, either this or that. It's more of a spectrum between the two. With the triaging questions, there are many questions that are asked, and these mainly focus on identifying the risk factors, which include advanced age, female gender, autoimmune disease such as Sjogren's syndrome, hormonal imbalances, contact lens wear, environment, use of certain medications such as antihistamines and antidepressants, and of course iatrogenic causes of dry eye disease such as surgery and certain drops. Now, when it comes to the diagnostic approach, usually the recommended direction is to start with the survey of the symptom severity, and the universally acknowledged and accepted and most commonly used, I think, is the Ocular Surface Disease Index. The issue we have in the Arabic world is that we don't really have a validated Arabic version of this index, but we do have a translation of that we use in our setting. Ocular surface staining, as we've just heard in the previous presentation, is an important part. You can use fluorescent lissamine green or rose bengal. What I would like to highlight here is the importance of doing this in a methodological manner and in a standardized way. So we use the Oxford scale for ocular surface staining when we record the level of staining, and this helps monitor the progression of the patient and compare with previous visits. Now, to test for aqueous deficiency, you can either do a Schirmer test without anesthesia. Usually this involves putting a strip in the outer third of the lower lid, leave it there for 5 minutes, and usually less than 15 minutes is considered abnormal. Less than 15 millimeters is considered abnormal, but less than 5 millimeters is certainly highly suspicious of aqueous deficiency. Tear meniscus height is an extremely useful way as well of assessing aqueous deficiency, and nowadays we have automated devices that can measure this. And then tear film instability and excessive evaporation can be assessed with the fluorescent tear film breakup time, and or using a non-invasive way of doing this by using certain diagnostic devices. Usually more than 10 seconds is the normal value for tear film breakup time. Lipid deficiency is probably the most common cause of dry eye disease. You need to really look carefully at the meibomian glands, assess the quality of the secretions. Meibography and lipid layer thickness is now becoming more popular. And finally, hyperosmolarity and inflammation. You can check that with osmolarity testing and MMP9 testing in clinic. Now, what I want to highlight here, and this is probably the most important part of my presentation, is the fact that you have diagnostic tools now to assess various parts of this pathophysiology slide of dry eye disease. You can check the tear hyperosmolarity, tear film instability, and the rest. Not to forget that you need to assess for incomplete blinking, conjunctival chalasis, floppy eyelids, lid irregularity, corneal sensation, and subtarsal scarring. So in essence, in my talk, I would like to emphasize that dry eye disease at its core is an inflammatory condition that results from loss of tear film homeostasis. When you assess dry eye disease, you need to standardize your evaluation, and we are moving towards using automated and validated tools for this. And we'll hear in the next presentation more about the management of dry eye disease, but it will need to take a holistic approach with focus on patient education and lifestyle modifications. Thank you very much for listening.
Thank you, Dr. Al-Maskari.